Welcome everyone. Today we're going to talk about beta blockers. As we've studied in our last video, we talked about the general principles regarding autonomic nervous system. Today we're going to talk about the beta blockers. To understand the beta blockers, first of all, we need to understand what are the beta receptors. Beta receptors are the part of sympathetic and or adrenergic part of the autonomic nervous system. And as you can see, there are three types of beta receptors. Number one, B1, for example, beta 1, that is the cardiac specific receptors. Beta 2, they are present into the blood vessels and different types of viscera. And number 3, the beta 3, example, adipocytes. These are the general classifications of the beta receptors. Now, what is the normal beta physiology? As you can see, beta 1 receptors are found in heart, kidney, and some presynaptic terminals. Beta 2 receptors are predominantly found in the smooth muscles relating to the bronchioles, liver, and skeletal muscle. Beta 3 receptors are adipocyte specific. Now, when the beta 1 receptors are stimulated, the heart rate increases. Heart contains beta 1 receptors in every part of it, for example, in SA node, in AV node, in the ventricular tissue. It also is present in the kidney and initiates renin secretion. Now, beta 2 receptors are present in the visceral muscle, bronchioles, liver, and skeletal. They got vasodilation, and all these effects. Beta 3 receptors increases the lipolysis. So these are the basic normal beta physiology of our human body. There is a lot of detail regarding this, but you just need to remember this much in general, and you keep in mind that whenever we stimulate this receptors, we get our normal physiological responses. But whenever we block these receptors, these responses becomes depressed. So this is the topic of our today's video. Now, beta blockers are the type of drugs that are classified on the basis of their receptor selectivity. As you can see, the beta blockers are classified on the basis of their receptor selectivity. For example, the beta 1 receptor specific, beta 2 receptor specific, or non-selective. Moving on to the classification, they are classified as first generation non-selective. The non-selective generation stimulates blocks both beta 1 and beta 2 receptors. There are the second generation of beta blocker that are more selective, and they are selective for beta 1 and beta 2 respectively. Now, second generation is also available for the beta 1 and beta 2. There are the third type of generation also available, but the third generation beta blockers have additional alpha blocking effect. Now, what do you mean here with the alpha blocking effect? Whenever we block the alpha receptor, for example, alpha 1 receptor, our blood vessels dilate. So, they may have the property with the alpha blocking or vasodilator property in any other way. We'll see it later on. Moving on, beta blockers. How do you identify a beta blocker from the classes of drug that are presented to you? It contains a suffix OLOL. Whenever a drug contains OLOL, OLOL, it means it is a beta blocker. Not I, not A, just OLOL. These are the beta blockers. Moving on to the first generation of the beta blockers that are non-selective for beta 1 and beta 2 receptors. They block both of the beta 1 and beta 2 receptors. As we know that the beta 1 receptors are cardiac specific receptors, so when we block these receptors, our heart rate will go down, our force of contraction will go down, our blood pressure will fall, our cardiac output will get low. And whenever we block the beta 2 receptors when stimulated, what do they cause? Beta 2 receptors cause the relaxation of our they are present into the smooth muscles of bronchioles. So we block them, their blood pressure effect, the beta 2 receptor is blocked, so vessels constrict. For example, propranolol, timolol, sotalol, pindolol, ledolol. Moving on to the second generation, there are the more selective blocker. These are for beta 1 receptors. They are the acebutolol, atenolol, pentaxolol, bisoprolol, esmolol, metoprolol. Now I want you to focus on this part here. Whenever we block the beta 1 receptors, these receptors are blocking their effects of adrenergic system on the heart. They decrease the heart rate, decrease the force of contraction, decrease the velocity of conduction of the nerve cardiac impulse, and also decrease the automaticity. But they spare their effects on the beta 2 receptors. So this is an edge here. We can give these drugs to a patient who is presented with diabetes mellitus and in need of the beta blocker. So this is the point here. I want you to focus on one thing here, like this A, B, P, E, M. All the beta blockers that are cardiac selective, they start with the letter A to the letter M. Every beta blocker starting with the letter A, B, C, not C, A, B, D, E, and till M are cardiac selective or beta 1 selective, except C. Now there is one more thing I want you to remember. The cardiac selective activity of the beta blocker is only valid at low doses. Whenever we increase the dose, they lose their selectivity. So this is something you need to remember. Now third generation. Third generation of beta blockers, as I told you earlier, they have a vasodilator effect that can be mediated by alpha blocking or any other property. So these are labetalol, carvedilol. These are the mixed alpha and beta blockers. As mentioned here, they block both alpha and beta receptors. Celiprolol and cartiolol. They are the beta 2 agonist activity. They are the partial intrinsic activity as beta 2 agonist or sympathomimetic activity. So these drugs stimulate beta 2 receptors and they cause vasodilator dilation. Nebivolol, nepranolol, they release nitric oxide and they cause vasodilation. Tilisterol, they block the potassium channels, they activate the potassium channels and they cause vasodilation. Carvedilol and butoxolol, they are the calcium channel blockers. Whenever a calcium channel is blocked, the blood vessels do not constrict as smooth muscles are dependent on the calcium channel entry for their contractility. So whenever we block the calcium channels, they cause vasodilation. So you have to remember this, that the third generation of beta blockers, instead of blocking the beta receptors, they also block alpha receptors or by any other mechanism they cause vasodilation. Moving on, now we were talking about a phenomena in which a beta blocker enters the central nervous system and block the beta receptor present there. What does this statement mean? Water soluble beta blockers without CNS entry and CNS effects. It means that the beta blockers which are water soluble and not lipid soluble does not cause any CNS effect. It means that whenever we give a beta blocker to a patient who is receiving a barbiturate treatment, what will happen? The beta blocker will enhance the action of barbiturate and the person will go from the sedative state to a coma state. So in that person, in that case, who is receiving a CNS stimulant or a CNS depressant, we will use the drugs that are water soluble so that it does not cross the blood-brain barrier and inhibit the and does not interact with the action of that specific drug. For example, atenolol, nadolol, sotalol. So ANS, you can remember this by this mnemonic. So if we give atenolol, as you can see, as we have talked earlier, it starts with an A. It means that this specific drug is a beta 1 selective. And moving forward, if we give this drug to a patient, if this we give this drug in hypertension in a patient who is receiving a barbiturate treatment, it will just depress the actions of heart and it will not cause any type of CNS effects. Different types of effects of beta blocker. There's the cardiac effects that are used in the treatments of conditions related to the heart. For example, hypertension, the cardiac effects, myocardial infarctions, tachycardias, chronic heart failures, and angina. These are the conditions in which we can use these type of drugs. Non-cardiac treatment. We can use these drugs in the treatment of glaucoma by preventing the production of aqueous humor from the beta receptors present there. Treatment of anxiety, thyrotoxicosis. Now this is a point I want you to highlight. Thyrotoxicosis. It means that excessive production of thyroid hormone, for example, thyroxine T3 or now the hormone thyroxine is produced in excess. There is only one beta blocker that blocks the action of thyroxine by decreasing its production. It inhibits the enzyme deiodinase and stops the conversion of D4 to T3, hence preventing the thyrotoxicosis-induced hypertension. They are also very helpful in treating pheochromocytoma, a condition in which the tumor is present in the adrenal medulla and it produces excessive catecholamines. Now there is a portal hypertension. It helps in the treatment of the portal hypertension. Moving forward to the overdosage. Whenever we overdose a beta blocker, it aggravates the effect of normal pharmacological effects. What does this statement mean? Its statement means that the overdosage and toxicity cause the aggravation and or exaggerations of the normal pharmacological effects. What were the pharmacological effects of the beta 1 blocker or beta 2 blocker or beta 1 plus beta 2 non-selective blockers or generation 3 beta plus alpha blockers? They depress the action of the heart, they depressed our blood pressure, they were used in the treatment reduction of aqueous humors, so they will decrease the glaucoma to a very low levels. So the overdoses will depress the normal physiological actions that we have studied of the beta receptor. Yes, do you remember? Like beta 1, beta 2 and beta 3, these three receptors will be completely wiped out and all the effects that were caused by these receptors will be blocked. Moving forward to the major contraindications, it means that these are some conditions in which you should never give a beta blocker. In patients who are asthmatics, if we give beta blocker to a patient who is asthmatic, it will aggravate his condition and it will worsen it even more. For example, if we give a non-selective beta blocker for decreasing the heart rate of an asthmatic patient, what will it do? It will dilate the bronchi to a very extensive level that it cause the aggravation of the condition and it will also depress the heart. So what should we give into the asthmatics? We give specific type of drugs that are beta 1 selective. We should not never give a beta blocker to a asthmatic patient. There are certain types of vasospastic conditions like Raynaud's phenomena or Prinzmetal angina. There are the two conditions, Raymond's phenomena and Prinzmetal angina. The Raymond's phenomena is a condition in which there is generalized vasoconstriction in the peripheral parts of our body. So whenever we give a beta blocker in such condition, it will worsen this condition. And there is also one type of Prinzmetal angina. Whenever we give a beta blocker in this condition, it will also lead to the heart attack or stroke. We should never give a beta blocker in a patient who is diabetic. What does this mean? It means that beta blocker decreases the insulin secretion. So it also decreases glycogenolysis, it also decreases gluconeogenesis. So a diabetic patient is without insulin. It means that it do not have much insulin, and also we are decreasing the intrinsic ability of our body to compensate with conditions like stress and fasting, and we are giving a beta blocker to a diabetic mellitus patient and we are also aggravating to this condition. So in this video the target was to study the major contraindications and major concepts that and major problems that are aroused in studying the beta blockers. And I want you to remember this, that you should always remember these conditions, that whatever happens, these are the basic points and these are the extract of the beta blockers. I want you to think about some scenario. If you want to just decrease the blood pressure, decrease the heart rate in a patient who is very tachycardic, what will you do? Will you give a beta 1 selective blocker, beta 2 selective blocker, or beta 1 plus beta 2 selective blocker, or generation 3 beta blockers? If you are thinking that beta 1 selective blocker, you are absolutely right. It means that beta 1 selective blocker will decrease the heart rate. We do not need any other effect. So you need to choose your drug very specifically, very carefully, that whether you're going to use generation 1, generation 2, generation 3, or you need to set your dose. You need to remember, you also need to focus on this point, that whether that drug can enter into the CNS, or whether that drug does not enter the CNS based on the lipid solubility. There are also some intrinsic sympathomimetic activity, like as we have studied in the generation 3 drugs, that beta 2 agonist activity, that is the partial sympathomimetic activity. Then you need to remember that things about the drug while studying the beta blockers. So that was all about today's video. I hope you liked it. If you have any query, just drop it in the comments and I will get back to you. And if you want any specific topic covered, just drop the topic from any subject